need to disclose that I advise breast milk and formula companies, but my talk today represents a 40-year-long area of personal interest. I want to take you back 2,400 years to the time Hippocrates made this iconic remark, "First, do no harm." If we're going to put that in a modern context, I believe that if we do an intervention in order to achieve a clinical benefit, then we have some kind of duty to understand, quantify, and minimize any risks of harm that could come from that intervention. And I want to apply that concept to the use of cow's milk products in the NICU. These have been immensely important for us, and we'll continue to use these, but they've been highly effective in promoting growth, but nevertheless pose a risk of adverse outcomes. And I want to examine that with you today. Now, satisfactory testing for the safety of preterm diets requires logical study designs. If you are looking at the safety of a new drug, your index groups might have different doses of the drug, but by and large, you would want your control group not to be taking the drug because that would confound the analysis. And that simple principle has often not been applied to testing the safety of cow's milk products. Babies can be fed partially or entirely on cow's milk, but ideally, the comparison group should not have been exposed to cow's milk. They should have been fed on an exclusive human milk diet. And there is the problem with the literature, because babies are often described as being exclusively human milk fed when cow's milk derived fortifier has been added to the breast milk, providing around 50% of the protein intake. So having large amounts of cow's milk in the human milk reference group and the cow's milk exposed group blunts comparisons, making safety difficult to quantify or even detect at all. If we take this trial by Chandler, he wanted to compare preterm formula with donor milk when mothers didn't produce enough milk. This looks like a nice study design, but the study failed to detect adverse impact of preterm formula, which had been shown over prior decades. And some clue as to why that might have occurred is derived from looking at the methods section in the paper, where you can see that cow's milk derived fortifier has been added to both mothers' milk groups and also the donor milk group. So this lack of difference between donor milk and preterm formula was plausibly methodological due to having large amounts of cow's milk in both limbs of the trial. So such flawed studies may potentially lead clinicians, and therefore our new approach to studying the safety of cow's milk is to exclude many studies where cow's milk exists in the exclusive human milk comparison group. So what randomized trials provide prolonged 100% human milk comparison group? Well, our historic trials compared donor breast milk with preterm formula as sole diets or as supplements to mother's milk in the pre-fortifier era. So this was an exclusive human milk diet being randomly compared to exposure to cow's milk. And there are actually 8 randomized trials in the pre-fortifier era of that design. And now we have a generation of modern trials where exclusive human milk is achieved with human milk-based products versus cow's milk exposure, and 6,000 subjects in cohort studies that compare the same diets. So my goal in the first part of this lecture is to quantify the impact of cow's milk on these 5 important outcomes using meta-analyses with those of you who have a statistical bent, using random effects models, which are very conservative, in appropriately controlled studies from all over the world. Now, I want to start with necrotizing enterocolitis. Here, uniquely, are the 7 randomized trials in the world literature where there's an exclusive human milk comparison diet. And I've set up this forest plot so that anything to the right of this line of no effect represents an adverse effect of cow's milk. You can see the summary diamond is well to the right, representing a significant 2.7-fold increased risk of necrotizing enterocolitis in babies exposed to cow's milk. And importantly, these early trials from the 1980s show exactly the same effect size as the later trials. Now, if we look at NEC incidence in these 7 randomized trials, 2.3% on an exclusive human milk diet, 6.7% in the cow's milk exposed group, but this depends on how much cow's milk you're exposed to. In those 7 trials, we have some that compare exclusive human milk with all cow's milk or with partial cow's milk feeding. And you can see that for the all cow's milk group, there's a 4.6-fold increased risk of NEC, whereas with partial cow's milk feeding, there's still a more than doubling of the risk of developing NEC. Proven sepsis. Here we have the 6 randomized trials with an exclusive human milk comparison group showing a significant 1.4-fold, that's 40% increased risk of proven sepsis in babies who receive cow's milk products. For mortality, the earlier studies seldom recorded death, but if we look at the modern trials, there's a 2.5-fold increased risk of death in babies who received a cow's milk product. Severe retinopathy of prematurity, major cause of blindness. You can see here that we have 1 randomized trial that examines severe ROP in relation to diet. And both groups had 100% human milk-based diet, and those who were randomly assigned to a cow's milk rather than a human milk-derived fortifier had a 6-fold increased risk of severe ROP. But to improve the estimation of the effect size, I've included this trial with 3 cohort studies of the right design, and you can see here a 2.3-fold increased risk in over 2,000 subjects in the group that was exposed to cow's milk, and also a 30% increased risk of bronchopulmonary dysplasia using a mixture of randomized trials and cohort studies in the cow's milk exposed group. So these are our new provisional relative risks of morbidities with cow's milk versus an exclusive human milk diet. Greater than we thought, and you can see the biggest effects for NEC, death, and retinopathy of prematurity. But these effects are still important. A 40% increase in sepsis is major, bearing in mind how common sepsis is. Now there is a new player in this field, patent ductus arteriosus. In 2016, Hare noted a highly significant increase in PDA with cow's milk exposure versus a modern exclusive human milk diet. And we decided to explore this in our large randomized trials. And our diagnosis of PDA was before the scan era based on clinical signs plus the need for either medical or surgical treatment. And you can see that if we compare donor breast milk as a sole diet or preterm formula as a sole diet, there's a 2.6-fold increased risk in the cow's milk group rather than the exclusive human milk group. And I've assembled all the studies that I can find that have the appropriate design, nearly 2,500 subjects, and you can see a 40% increased risk of patent ductus in babies who've been exposed to cow's milk. So the adverse effects of cow's milk pervade neonatology. Now, I want to take you on an adventure into the later effects of early cow's milk exposure, because cow's milk-based products affect later health in really quite diverse ways. One aspect I want to consider is that cow's milk exposure results in poorer feed tolerance, and that is an unexpected pathway to significant later morbidity. The key medical issue here is that worse feed tolerance with cow's milk means a potentially higher duration of hazardous parenteral nutrition. And I want to give you 2 examples with long-term effects. Parenteral nutrition solutions are heavily contaminated with aluminum, and we wondered whether parenteral aluminum could adversely affect the brain and bones of preterm infants, as it did in the past in renal dialysis patients. So we did an aluminum trial comparing regular parenteral nutrition with parenteral nutrition with 90% less aluminum. We published this in the New England Journal. And essentially, you lose one mental development index point, that's like an IQ point, for each day of standard parenteral nutrition in the NICU. And at 13 to 15 years follow-up, the standard parenteral nutrition group had reduced lumbar and hip bone mass, which are risk factors for later osteoporosis and hip fracture. Now, if you have an increase in parenteral nutrition, you're likely to have an increase in parenteral lipid. And parenteral lipid is dose-related, we found, to arterial stiffness at our 25 to 28-year follow-up. And at that stage, arterial stiffness is highly predictive of an increased risk of major cardiovascular events, notably a heart attack or a stroke. So cow's milk increases the need for parenteral nutrition. That, in these examples, increases aluminum and parenteral lipid exposure with some rather major adverse long-term outcomes. And it's this indirect effect on cognitive development I want to focus on, because there are possible further indirect adverse impacts of cow's milk-based products on neurodevelopment. Cow's milk increases the risk of NEC and sepsis, and numerous studies link NEC and sepsis to adverse neurodevelopment. Our most recent analysis is submitted for publication based on our 30-year follow-up and shows that infection and NEC are associated with lower full-scale IQ and performance IQ at 7 and at 30 years follow-up. And we've also found that after adjustment for confounding, babies with NEC are 3.4 times more likely to develop cerebral palsy, and even those with sepsis are 2.2 times more likely to develop cerebral palsy. Now, cow's milk is also linked to respiratory disease, and there's increasing evidence that respiratory disease may be associated with reduced later IQ. And to show you our own data here, each day of ventilation we found was associated after adjustment with a 4.4 point lower verbal IQ 7 to 8 years later, and BPD with a 5 point lower verbal IQ. So the hypothesis I'm developing here with you is that if you expose babies to cow's milk products, there are a number of morbidities that they may have in the neonatal period, each of which is associated with adverse neurodevelopment. And that's only one thread linking cow's milk with the brain. Cow's milk products may provide suboptimal levels of certain brain nutrients, such as sphingomyelin and cholesterol, and also may derange the gut flora, which could theoretically adversely affect the brain through the gut-brain axis. But that is the theory. If that theory is correct, then those babies who are fed on cow's milk should have worse neurodevelopment. That was shown by Amy Hare last year, looking at 250 babies less than 1250 grams. And what she found was that the cow's milk exposed group had a 7-point lower cognitive score compared to an exclusive human milk-fed group. That's half a standard deviation loss of cognitive potential in those who are cow's milk exposed. If we look at our historic trials, I'll just give you an example. We have bank breast milk versus preterm formula again, and you can see that the arithmetic score at 7 to 8 years of age was 21% lower in the preterm formula group, despite the fact that there was a much greater nutrient content of preterm formula versus donor milk. We've been looking at the brain in those fed cow's milk products for some years, and aside the lower cognitive and math scores, we found that at follow-up, these babies end up as adults with a smaller brain on MRI and less white matter and myelin in the brain, which is a basis for connectivity. And a couple of years ago, there was an observational study by Cortez showing that brain damage in the form of periventricular leukomalacia was at a higher incidence in those who are fed on a cow's milk-derived preterm formula rather than mother's milk. And the same has occurred now in another study just this year. Severe PVL or severe IVH were related to cow's milk exposure with a much higher incidence than those who are fed on an exclusive human milk diet. So cow's milk may relate to the brain in a number of ways in terms of reduced cognitive scores, reduced long-term brain size, reduction in myelinization, and now this new association with severe brain damage. I want to move on to talk about the programming of cardiovascular disease, which is the commonest cause of death in the West. If we look again at our historic trials comparing an exclusive human milk diet with exposure to cow's milk, you can see that those who are randomly assigned to cow's milk in the newborn period ended up 16 years later with 5 key risk factors for adult cardiovascular disease: raised blood pressure, LDL cholesterol, insulin resistance, tendency to fatness, and an inflammatory marker. And these effects were not minor. The observed increase just in adult cholesterol level with early cow's milk exposure would in adults be expected to increase cardiovascular disease by 25% and death by 14%. And the estimated impact of cow's milk on later blood pressure was greater than that achieved through lifestyle modification in adult life. So two really important outcomes here for humans, cognitive development and the most major cause of death, are really quite strongly related in our own studies to early cow's milk exposure. And there are further programmed effects as well. If you randomly assign babies to cow's milk in the newborn period and they have a positive family history of atopy, then we found that they were programmed for a future risk of food and drug reactions, eczema, and wheezing. Cow's milk exposure is associated with reduced bone mineralization at 20 years follow-up, which could relate to risk of adult degenerative bone disease, and it also adversely affects the development of the heart itself. This was investigated by my colleague, Adam Lewandowski, who did cardiac MRIs at 25 to 28-year follow-up of our preterm randomized trials, and found that the exclusively cow's milk fed group in the neonatal period had in adult life much smaller left and right ventricles, 18% reduction in the size of the right ventricles, and smaller stroke volumes, which of course have functional significance for cardiac performance. So I've shown you 15 adverse effects of cow's milk that have been demonstrated in strictly randomized trials, and in some instances, meta-analyses of randomized trials. There are also 7 more adverse outcomes that come from cohort data and 5 proposed indirect adverse effects as well that I've demonstrated to you. So the generic mechanisms that might explain this adverse impact of cow's milk could actually be simply the displacement by cow's milk of the benefits of human milk, or it could be direct adverse impacts of cow's milk itself, or possibly the adverse impact of cow's milk fortifiers on human milk biology, or it could be a combination of those. But regardless of mechanism, there is growing evidence that those exposed to cow's milk show broad adverse outcomes. And importantly, this is notable in extremely premature babies. So part of my objective in the first part of my talk was to use good study designs to quantify the adverse impact of cow's milk products. So why would we want to quantify safety here? Well, the first is to test for quality improvement. A modern trend in preterm infant feeding, supported by official recommendations, is to use donor breast milk if mother's milk is insufficient. Well, this is standard practice. We've done this for 40 to 50 years, used mother's own milk, and in recent decades added a cow's milk derived fortifier, and if there wasn't enough mother's milk, we've used a preterm formula. And what has now emerged as recommended practice is to get rid of the preterm formula and use donor breast milk in Western countries, and that has resulted in a human milk-based diet, most generally fortified with a cow's milk derived fortifier. The question is whether this emerging practice has actually improved safety. So we did a meta-analysis to test the safety of cow's milk derived fortifier in modern practice, which were recently published. 3 studies where the babies had 100% human milk-based diet and where it was possible to compare a cow's milk with a human milk-derived fortifier. And we found that compared to the human milk-derived fortifier group, the ones fed on the cow's milk-derived fortifier had a 3.3-fold increased risk of NEC, 2.4-fold increased risk of retinopathy of prematurity, and a 60% increased risk of PDA. Now, a common strategy to increase the power of studies is to combine morbidity outcomes as a mortality morbidity index. And the one we used was the positive index was diagnosed if one or more of the following occurred: death, NEC, sepsis, ROP, or BPD. And when we did an analysis of the morbidity index in the 3 studies, it was 40% higher in the cow's milk-derived fortifier group. So our meta-analysis showed that cow's milk-derived fortifier was linked to increases in individual nutrients and also to multiple outcomes embedded in a morbidity index. Well, now we can begin to start looking for differences between standard and current practice. And this is very early stage data, but if we just focus on the right-hand column here, this is looking at the increased relative risk for a disease process in the cow's milk group. So it's 3.3-fold increased risk of NEC, 2.4-fold increased risk of ROP, 60% increased risk of patent ductus. And what you'll notice is, crudely, that there is very little difference between the relative risk for current practice and for standard practice. And at this stage, although we have much more work to do, despite 100% human milk-based diet, we've found no clear quality improvement. And our data appear to show that the cow's milk-derived fortifier may offset the benefits of using donor milk. Another reason why you might want to quantify safety is to address specific issues like, is it really true that there is no benefit of donor milk once it's been pasteurized compared to cow's milk products, which has been claimed by a number of neonatologists? Well, randomized trials are only possible for donor milk or donor breast milk products versus cow's milk. It's unethical to compare mother's milk with cow's milk. So all these 15 outcomes here derived from randomized trials have all been the results of comparing donor breast milk with preterm formula. And you can see that the cow's milk groups, as I presented my talk, have had greater morbidity. A third reason why you might want to quantify safety is to estimate population morbidity. Now, meta-analyses are often used to calculate relative risk, but we can also use them to estimate population risk based on assuming that the available studies are representative of the population you're studying. Since that might not be true, these data are very tentative, but I presented morbidity in UAE and Saudi that's estimated if babies are fed on cow's milk rather than an exclusive human milk diet. So what you're looking at is additional cases that could be potentially attributed to cow's milk and therefore potentially preventable. And you can see 400 cases of necrotizing enterocolitis, which would probably include about 100 deaths, 600 cases of retinopathy of prematurity, which would probably include 30 cases of blindness or severe visual impairment, and 900 cases of patent ductus arteriosus each year. And of course, you'd like to see these broken down. Obviously, UAE is smaller than Saudi, but this is still an important burden of estimated additional morbidity. And then the additional cases of having a positive morbidity mortality index, if fed on cow's milk, would be 1,400 cases per year for Saudi and UAE, and 200 for UAE. But I do want to emphasize that such population data are approximate, but they'll become more robust as further data is collected, particularly from the Middle East. Now, finally, you might want to quantify safety for health economic studies. reliable data on the burden of morbidity in each population is key to health economic analyses. And some of these outcomes have been costed and have turned out to be expensive. But a lot of these things have not been looked at all. If we take coronary artery disease, that costs $225 billion a year in the USA. Prematurity is a risk factor, and we should know the impact of cow's milk exposure on this has not been costed yet. So how should we respond clinically to morbidity due to cow's milk? What are the options? Well, it's been suggested by some that we have no fortification or delayed use of cow's milk or use hydrolyzed fortifiers. And research should continue with these things, but none of these are evidence-based strategies. What we have found is that every stage, historically, when we've compared cow's milk with an exclusive human milk diet, we have seen that deleting cow's milk or deleting preterm formula or both reduces numerous morbidities. So I've taken you on an evidence-based journey, looking at cow's milk with appropriate studies, and cow's milk emerges as a safety issue. In fact, it's one of the more diverse influences on risk of harm that we have in neonatology. Is this new? Not really. By the middle of the 20th century, we had extensive concerns about the safety of cow's milk products for full-term infants, and even today, with the most modern formulas, there are purported advantages of breastfeeding in these respects compared to formula feeding, and that's, of course, why we promote breastfeeding. So against that background, my first message is that cow's milk-derived products are generally recognized to have adverse effects. What is new about what I presented is that it's the extremely preterm infant that appears least adaptable to cow's milk, with a really major burden of morbidity. Secondly, so far we've not demonstrated any evidence that the modern diet providing all human milk with a cow's milk-derived fortifier has improved safety. The third point is that whether we look in the past or the present, the evidence suggests that excluding cow's milk is linked with less morbidity versus a diet including cow's milk. So my final message is this: cow's milk products are of immense value in neonatal intensive care, and we would never have been able to manage nutrition effectively without them. But for extremely preterm infants, the use of cow's milk needs rethinking. Thank you.